questions. So don't forget to type all of them on the Q&A chat box. Follow us on social media. You're going to be able to find about our next meetings. And please register, subscribe to our YouTube channel, and all of our activities are recorded there. So during this month of March, we have a lot of activities prepared, especially to all of you. We are very, very proud to have done all of this work for you, and I'm sure this is going to be awesome. So starting with Dr. Anderson's series. So today we are going to talk about VSDs, and with Dr. Diane Spicer and all the panelists debating that. And then every Friday, we are going to talk about a different topic. So please register for the series and join us every Friday. We have Dr. Silverman's series as well, once a month. Next one is going to be next Monday, the 8th of March, talking about anomalous pulmonary venous connection. I'm sure this series is continue to be amazing. Everybody loves it. This correlation between morphology and echo images, and the way he explains is just amazing. I'm sure all of you is going to enjoy a lot. We have something new that we are proud to announce. We have an Ecg series. This is very interactive. This is a very nice series. Dr. Volkan is a well-known electrophysiologist, pediatric electrophysiologist, and he's doing this series. 1 week it's in English, and the other week is in Turkish. He is Turkish. So every other week, the series is in English. He shows ECGs with a lot of arrhythmias or any other type of diseases, and then he discusses about it. He asks the audience to type their thoughts about that ECG, about the diagnosis, about the treatment, and it's very interactive, and everybody learns a lot. So please join us on this series. This is very nice. We are very happy to continue to have Dr. Gil Vernovsky with us, talking about pediatric cardiac intensive care. The next one is going to be on Thursday, 11th of March, talking a little bit more about transposition of great arteries. He's going to debate the transitional circulation and the early post-op care. Please join us on that. And Dr. Mary Cohen, amazing Dr. Mary Cohen, is continuing her series with us as well, with her outstanding echo images. So she's going to talk on the 22nd of March about imaging after surgery for single ventricles. This is going to be awesome. Please join us on this webinar too. And to wrap up the month, we are going to have another Phytocardiology series. This is going to be a very practical one with a very practical approach. People are going to show how they do things in a practical way. So it's going to be very nice. They are going to start with Dr. Gustavo Fávaro from Brazil. He's going to give an overview about the fetal echo, how he does it to rule out when he gets a pregnant lady who has no suspicions of diseases. He's going to show us how he rule out all the diseases that the fetus can have. And then Simone is going to talk about heart failure and hydropsy, and Claudia is going to talk about arrhythmias, and then Marina is going to show interesting cases. This has been a very nice series that Dr. Rima is organizing, and we are very happy to have this series as well. So guys, please enjoy Dr. Anderson and Dr. Diane today, and all the panelists. Type your questions in the Q&A chat box, and I'm going to give all of these links for all of these webinars on the chat box as well. Welcome, everybody.
Well, good afternoon again, ladies and gentlemen, and welcome to our ongoing discussion of remodeling the embryonic interventricular communication. What we're going to do today is we're going to show you how, on the knowledge that we've accrued over the last few weeks, we can now understand the differences between the different types of so-called isolated ventricular septal defects. Now, you'll remember that last week, we looked at the different types of communications between the ventricles. And I pointed out to you that some of those defects could be interpreted on the basis of persistence of what we now know is the primary interventricular communication. And you'll remember that those are the channels we see when we have a dominant left ventricle receiving the entirety of the atrioventricular junctions. In other words, double inlet left ventricle, classical tricuspid atresia, absence of the left atrioventricular connection when the right atrium is connected to the dominant left ventricle. We discussed how, after the first part of remodeling of the embryonic interventricular communication, we had what we can call the secondary communication. And Sasha pointed out to you that that channel becomes the outflow tract in normal development, but persists as the interventricular communication in the setting of double outlet right ventricle. And as he pointed out, the key then for the surgeon is to close the right hole. We went on to point out that if development progressed normally, we then had what we could consider the tertiary interventricular communication. And that is the communication we're going to be concentrating on in the latter part of today's presentation. It is closure of that tertiary foramen that completes ventricular septation. So before we look at any of these phenotypes of isolated ventricular septal defects, we're going to start off by showing you the features of the heart after the completion of normal septation. So to start off, Diane is going to illustrate to you the features of normal septal structures. She's going to emphasize to you that the membranous septum is very small. The larger part of the septum is muscular. Part of that interposes between the inlet of the right ventricle, the outlet of the left ventricle, and then she's going to show you that in the normal heart, there is no muscular component that we can consider to represent an outlet septum in the normal heart. And then we're going to relate all this key information to what you see in the presence of deficient ventricular septation.
We'll begin our discussion today with a review of some of the normal structures we'll be referring to throughout the ventricular septal defect discussion. This is the opened right atrioventricular junction in attitudinally appropriate position, and we can see the tricuspid valve guarding the inlet with its inferior, septal, and anterior superior leaflets. Within the right ventricle, we have a prominent septal structure, which is the septomarginal trabeculation. Here's its body, and it has two limbs, a cranial or cephalic limb that rises up to, in part, support the pulmonary valve within the subpulmonary infundibulum, and then the caudal or posterior inferior arm. And this gives rise to the medial papillary muscle, which supports the zone of apposition between the anterior, superior, and septal leaflets. And deep to this zone of apposition is where the membranous septum is located, and we'll look at that a little bit closer from the left ventricular side. But while on the right ventricular side, I would like to show you the landmarks of the triangle of Koch. Here is the oval fossa. The coronary sinus lies at the base of that triangle, and one arm of the triangle is formed by the hinge point of the tricuspid valve. The remaining arm, if I tug on the eustachian valve, we can see the tendon of Tadaro extending down to the apex of that triangle, and in this area is where we're going to find our atrioventricular conduction axis. If we draw a line from the apex of the triangle of Koch to the medial papillary muscle, we can see the atrioventricular conduction axis as viewed from the right ventricle. Looking at the membranous septum from the left ventricular side, here we can see the apical trabecular component, the inlet of the left ventricle guarded by the mitral valve, and in this area, the anterior or aortic leaflet of the mitral valve is in fibrous continuity with the aortic valve. And it is typically in fibrous continuity with the non-coronary leaflet. Adjacent to the non-coronary leaflet, we see the right coronary aortic sinus, there's the right coronary orifice, and the right coronary aortic leaflet. At the base of the interleaflet triangle between the non-coronary and right coronary aortic leaflets is where we see the membranous septum. You can see that it's a very small component of the total interventricular septum, and on the right ventricular side, it is divided by the septal leaflet of the tricuspid valve, giving us an interventricular and an atrioventricular component. Many of the defects that we'll be discussing today occur in the area of or along the borders of the membranous septum, hence the name Perimembranous. While we're on the left ventricular side, we should also mention that the mitral valve is barely attached to the interventricular septum, and this is secondary to the centerpiece of the heart, or the aorta, being deeply wedged between the atrioventricular valves. In the interest of time, I don't have time to show you the short axis view, confirming that this portion of the septum is actually an inlet-outlet component. And so I'm going to place a pin in the septal component of the left ventricular outflow tract and show you that it exits within the inlet portion of the right ventricle. So this portion of the ventricular septum is actually an inlet-outlet septum. We also have the apical trabecular component and the outlet component as viewed from the right ventricle. In the past, this area here, where the supraventricular crest joins between the limbs of the septomarginal trabeculation, used to be considered as a component of the outlet septum. If the heart develops normally, there is no outlet septum. The supraventricular crest and the subpulmonary muscular infundibulum are lifted up off of the right ventricular mass, and we can pull those structures away from the aortic root. Here is the right coronary artery, and this subpulmonary muscular infundibulum in this area can be lifted away from the left ventricular outflow tract. I have a dissection that shows us this quite nicely in a somewhat larger specimen. The free wall of the right atrium, arterial trunks, and right ventricle have been cut away. This is the pulmonary valve. You can see the cranial arm of the septal band extending up to the pulmonary valvular leaflets. Here's the medial papillary muscle, which arises from the caudal arm of the septal band. And here, between the pulmonary and aortic trunks, you can see the subpulmonary infundibulum, which lifts it away from the ventricular mass. That fatty tissue plane is easily appreciated, which also continues down between the left ventricular outflow tract and where the supraventricular crest inserts into the Y of the septal band. Also in this area, the base of the interleaflet triangle between the non-coronary leaflet and the right coronary leaflet, which has been removed, is bordered by the membranous septum, and you can see how small this component of the interventricular septum is. The tricuspid valve crosses the membranous septum on its right ventricular side, leaving us with an atrioventricular component and a component that represents the interventricular component.
So now you've seen what happens in the setting of normal ventricular septation. If we think of the developmental steps that are involved in producing those septal structures, the muscular septum, the membranous septum, we can now take apart the steps that are involved in creating normality. And what we're going to do now is to illustrate to you the different phenotypes that you can find if those procedures do not occur in normal fashion. And we're going to start off by considering the effect of incomplete expansion of the atrioventricular junction. Now, you know that normally the junction does expand properly, and that gives us the tricuspid valvar orifice. We're then going to look at what happens with formation of that extensive muscular ventricular septum. And we're going to discuss how you can have holes within that muscular septum. Then I'm going to explain to you again how the embryo builds a myocardial shelf in the roof of the right ventricle. And we're going to discuss how that is akin to the surgeon tunneling the interventricular communication to one or other ventricular outflow tract in the setting of double outlet right ventricle. But then we're going to emphasize the fact that the completion of normal development is closure of that communication between the aortic root and the right ventricle. And as you will recall, we call that the tertiary interventricular communication. So let me remind you of the steps that get us towards the tertiary interventricular communication. And the first step there is expansion of the right atrioventricular junction. And that is associated with straddling and overriding of the tricuspid valve. So to look at our first phenotype of ventricular septal defect, we're going to look again at hearts with straddling and overriding of the tricuspid valve. The phenotypic feature of these hearts is malalignment between the atrial and the ventricular septal structures. And it is because of that malalignment that the atrioventricular node does not take its origin from where Diane has shown you in the normal heart, the apex of the triangle cock. So we're going to look again at this heart. It's the heart prepared by Lodewijk van Meerop from the University of Florida Archive in Gainesville. Diane's going to demonstrate this heart to you again, and she's going to show you where we get that anomalous atrioventricular node. So let me remind you why we get the anomalous atrioventricular node. This is the image I showed you last week, and it shows what has happened after we have had expansion of the right atrioventricular junction, because that gives us the vestibule of the tricuspid valve. And you'll remember that having expanded the right atrioventricular junction, the part of the initial interventricular communication can now be recognized as the secondary interventricular foramen. But you'll also remember that these images were prepared by combining them with an antibody to the nodose ganglion of the chick heart. And that antibody is showing us what will become the atrioventricular bundle. And after normal expansion of the atrioventricular junction, that muscular ventricular septum is in line with the atrial septum. And you can see part of that ring within the atrial septum. But what you also see is that after that expansion, part of the ring remains in what will become vestibule of the tricuspid valve. And if expansion is not normal, that persisting part of the ring can produce an anomalous node inferior in the right atrioventricular junction. And that is what Diane will now show you using the Van Meerop heart.
We'll begin our discussion first with those hearts that have straddling and overriding of the right atrioventricular valve. And this is that beautiful heart prepared by Dr. Van Merup at the University of Florida. The ventricular septal defect is here with the tendinous cords attaching across the crest of the ventricular septum and a few cords along the crest of the ventricular septum. Looking at the right atrium, we can see the oval fossa, the coronary sinus, and pulling back the anterior superior leaflet allows us to see the crest of the interventricular septum, which runs the entire length of the right atrioventricular orifice. Looking at the left ventricular side, the left atrioventricular valve is here, and the right atrioventricular valve straddling and overriding the interventricular septum. There are the tendinous cords attaching within the left ventricular side, and it is partially committed to the left ventricle. The remainder is overriding the septum and committed to the right ventricle. This specimen also shows us nicely that there is a perimembranous ventricular septal defect because we have fibrous continuity between the tricuspid and the mitral valves, as well as fibrous continuity between the aortic valve and both of the atrioventricular valves. If we look at the right atrial aspect again, the oval fossa, the coronary sinus, and here we can see the apex of the triangle of Koch. And secondary to the atrioventricular septal malalignment, there is no way the conduction axis can arise from a regular node at the apex of the triangle of Koch. In this particular case, the conduction axis is where the malaligned muscular ventricular septum meets the inferior atrioventricular junction. So you end up with an anomalous node just in this area where the malaligned ventricular septum comes up to meet the atrioventricular junction inferiorly.
So having expanded the right atrioventricular junction, the embryo is now in a position where it can form a muscular ventricular septum. And we see the first steps of formation of that muscular septum after the apical trabecular components have so-called ballooned from the primary heart tube. Now, to understand this process, we have to consider the so-called process of compaction, because a lot of hot air is appearing these days about so-called ventricular non-compaction, because it is still thought that the ventricular walls themselves compact, and this is not true. The compact walls grow from the outset, from the initial compact layer of the ventricular myocardium, and the trabeculations within the ventricular walls largely regress. But that is not the case for the ventricular septum, because the ventricular septum does form by coalescence of pre-existing trabeculations. So let's look at that. And let's look again at the steps that permit us to build the muscular ventricular septum. Now, you've seen this several times before. You will remember it is one of the reconstructions made by Wout Lammers, Jill Hicks-Poors from the University of Maastricht. It's Carnegie stage 13. And by now you'll be recognizing the atrioventricular canal. And there you see the developing trabeculations of the left ventricle. They're growing from the inlet part of the ventricular loop. So there you see the trabeculations of the right ventricle. They are growing from the outlet of the loop, which at this stage supports the entirety of the outflow tract. So you'll remember again that I've shown you this episcopic data set several times, which replicates what you've just seen from that interactive PD file. So there you're looking at the ventricular surface of the atrioventricular cushions within the atrioventricular canal, which is supported exclusively by the developing left ventricle. There is a primary interventricular communication, and there you see the apical trabeculations beginning to appear of the developing right ventricle, which is supporting the entirety of the outflow tract. So here is now the focus of our attention, because there is the beginnings of the muscular ventricular septum. And as you see, it is developing from the trabecular part of the wall. And if I show you this image of a mouse heart subsequent to the completion of ventricular septation, you can see the beginning of formation of the compact wall. You can see that is independent of the trabeculations. The trabeculations themselves parietally are going to regress. But what you can also see is how the septum is formed by coalescence of these trabeculations. And you know that I've shown you several times mice in which we have perturbed the furin enzyme. And one of the effects of perturbing the furin enzyme is that we exaggerate the way that the septum comes together by coalescence of pre-existing trabeculations. And here now in this mice, you see the compact wall is growing, but there are multiple passageways that are percolating their way through the muscular septum. And this means we can have holes at any point within that muscular septum.
To continue with our discussion of ventricular septal defects, we're going to move on from perimembranous ventricular septal defects with a fibrous posterior inferior border to talk about those defects that now have entirely muscular borders. This particular specimen has a muscular ventricular septal defect that is extending into the inlet component of the right ventricle, and you can see that it's partially shielded by the septal leaflet of the tricuspid valve. When we talk about the location of the conduction axis with muscular ventricular septal defects, this one entering into the inlet of the right ventricle. Here we see the coronary sinus, the tendon of Tadaro, and the hinge point of the tricuspid valve. This is the area where the atrioventricular conduction axis will be located, and you can see that it runs in anterior superior position relative to the borders of this muscular inlet ventricular septal defect. This particular specimen coexists with a perimembranous ventricular septal defect, and this was a common arterial trunk status post repair. You can see the complete subarterial muscular infundibulum, and at the posterior inferior border of this defect, the fibrous continuity between the tricuspid and the mitral valve. In this particular specimen, here you can see how the conduction axis from the apex of the triangle of Koch will run along the posterior inferior border of the perimembranous ventricular septal defect, but within this muscle bar that is anterior superior to the muscular inlet ventricular septal defect. Looking at the left aspect of this muscular inlet ventricular septal defect, this is the mitral valve, and there are the muscular borders of this defect. When there is a muscular ventricular septal defect, typically the membranous septum is intact and the conduction tissue will run in anterior superior position to the muscular border of the defect. But in this particular case, as we saw nicely from the right ventricular aspect, there is a perimembranous ventricular septal defect. the conduction axis will run in this muscle bar along the posterior inferior aspect of the perimembranous defect and anterior superior position to the muscular defect. I want to show you this specimen from the left side to show the left ventricular outflow tract and the intact membranous septum. In the last heart, we weren't afforded this secondary to how the heart was opened, but you can see the mitral to aortic valve fibrous continuity and the very well-formed membranous septum beneath the junction of the right coronary aortic sinus and the non-coronary aortic sinus. In this particular specimen, there are a few mid-muscular and a couple small apical ventricular septal defects, and the conduction axis would penetrate the atrioventricular component of the membranous septum along the posterior inferior border and run in its normal position in this particular heart with several mid-muscular and apical ventricular septal defects. The right ventricle in this particular case has been windowed, so the anterior free wall has been removed. There's the tricuspid valve inlet and the septal band. You can see the medial papillary muscle. In this particular case, there are multiple muscular ventricular septal defects. Muscular defects can occur anywhere over the septum, and within the right ventricle, these multiple muscular ventricular septal defects towards the apex are sometimes difficult to see, secondary to those coarse apical trabeculations that characterize the right ventricle. In this particular case, there is one defect that is well seen. There are several other behind some of these right ventricular trabeculations. The conduction axis will run in its normal position. In this particular case, the membranous septum is intact and the conduction tissue will run in its normal position so that the atrioventricular conduction axis will be distant to the muscular ventricular septal defects at the apex. Looking from the left ventricular aspect, which has also been sectioned by cutting a window in the free wall, here's the mitral valve, and backlighting and tilting the specimen upwards shows us that the membranous septum remains intact in this particular specimen. The muscular ventricular septal defects at the apex are multiple and also lie behind the multiple trabeculations at the apex of the left ventricle. These trabeculations are finer than what we see on the right. With the use of a light, we can see where those multiple apical ventricular septal defects are occurring from the left ventricular aspect. Hearts with these multiple apical muscular ventricular septal defects are often referred to as having a Swiss cheese interventricular septum.
So what you've now seen from the images and the hearts that Diane has shown you is that according to the way that the ventricular trabeculations compact or do not compact, holes can exist anywhere within that muscular septum. So Diane's shown you that they can open to the right ventricular inlet. You can have a Swiss cheese defect. They can open in the middle of the apical septum. But what Diane has not shown you yet is that defects can also open to the ventricular outlet. But there is an additional factor that comes into play with outlet defects because they reflect inappropriate formation of the myocardial shelf that the embryo builds within the roof of the right ventricle. So let me remind you again what happens as the embryo builds the shelf. And so here we have to look at the mouse heart at embryonic day 12.5. It's a 4-chamber cut. And there you see the proximal outflow cushions. The arrow there is pointing to what we call the parietal cushion. Now I'm showing you the septal cushion. Is that the two cushions have fused. And in fusing, they have built the shelf in the roof of the right ventricle that is creating the tunnel. The embryo is doing exactly what the surgeon does in the setting of double outlet right ventricle with subaortic defect. And by building this tunnel, the embryo now has connected the aortic root up to what was the secondary interventricular communication. And by building this tunnel, the secondary interventricular communication will become the outflow tract for the left ventricle. So muscularization of those proximal cushions does the same thing that the surgeon does, converts the secondary interventricular foramen into the left ventricular outflow tract. But if that shelf is incomplete, then a defect can remain between the aortic root and the right ventricle. And if in addition to that, there is the formation of trabecular compaction along the posterior inferior margin of the defect, then we can have a muscular outlet defect. Its phenotypic feature, in fact, will be the presence of an intact ventricular septum, because those trabeculations will have formed a myocardial posterior inferior border defect. We see such defects in the setting of tetralogy of Fallot. They are malalignment muscular outlet defects. The key, as Diane is going to show you, the caudal myocardial margin is formed by fusion of the limb of the septomarginal trabeculation, which you've already seen in the normal heart, and that fuses with the ventricular infundibular fold to produce that muscular posterior inferior rim of the muscular outlet defect. And that now is what Diane is going to illustrate for you.
The anterior wall of this right atrium, right ventricle, and arterial trunk have been removed. So we're looking at the septal surface in this heart that has transposition of the great arteries. So that this is the aorta arising from the right ventricle. You can see the right coronary artery extending towards the right atrioventricular groove. There is also an atrial septal defect, and this muscular ventricular septal defect extends into the outlet of the right ventricle. There is malalignment of the outlet septum, which allows the defect to open between the limbs of the septal band. In this particular case, there is also some degree of hypoplasia of the outlet component. It's important to look at the borders of this defect along the posterior inferior aspect, and you can see that the caudal limb of the septal band is intact and joins the inner heart curvature. So that the conduction axis in this particular case, we see the apex of the triangle of Koch here. We draw a line to the medial papillary muscle, and we can see that the membranous septum remains intact, and the conduction axis will run within this muscle bar away from the edge of the defect, where the surgeon will place his sutures to repair this ventricular septal defect. If we look at this from the left side, here we see the intact membranous septum, and this muscle bar, which is the outlet septum, extending along the posterior inferior border of the defect between the aortic valve and, in this particular case, the pulmonary valve as it exits the left ventricle. The pulmonary trunk also slightly overrides this outlet muscular ventricular septal defect. The conduction axis will then emerge from its usual position where the atrioventricular portion of the membranous septum joins the crest of the muscular ventricular septum, and within this muscular posterior of the defect.
You've seen that we can have a muscular defect opening to the outlet of the right ventricle. And the margins of that defect, posterior-inferiorly, we have that myocardial border. Cranially, we have the muscular outlet septum. And we know that that muscular outlet septum is formed from muscularization of those proximal outflow cushions. But those proximal outflow cushions themselves have to be hypoplastic to give us the muscular outlet defect. But what happens if the cushions fuse, but they do not muscularize? Then we have a fibrous outlet septum. It obviously will not fill that space in the roof of the right ventricle. So in this setting, we're going to have a defect. Its phenotypic feature will be fibrous continuity between the leaflets of the arterial valves because it will be juxta-arterial. And we know from our mice hearts again, in which we have perturbed the furin enzyme, that that is exactly what happens. So I've shown you this picture before. There you see the developing aortic valve. There you see the developing pulmonary valve. The intermediate part of the outflow tract is separated appropriately. The cushions have fused, but they have not muscularized. So now we are going to get a fibrous outlet septum, leaving behind the ventricular septal defect, opening between the outflow tracts in juxta-arterial position.
So far, we've looked at perimembranous ventricular septal defects and muscular ventricular septal defects. And this is a third type of ventricular septal defect, namely the doubly committed and juxta-arterial ventricular septal defect. This defect also can be defined on the basis of its borders. It opens to the outlet of the right ventricle between the limbs of the septal band. So it is an outlet defect. This defect is bordered cranially by fibrous continuity between the aortic valve on the left side and the pulmonary valve on the right side, and it is formed secondary to failure of the formation of the freestanding muscular infundibular sleeve, so that there is hypoplasia of this area during development. The phenotypic feature, as I already stated, was the fibrous continuity between the pulmonary and aortic valves in its roof. And in this particular case, there is a posterior inferior muscular rim, so that the caudal arm of the septomarginal trabeculation is joining with the inner heart curvature or the ventriculo-infundibular fold, and this muscle bar interposes between the tricuspid valve in the right ventricle and the mitral valve in the left ventricle, and in between the tricuspid valve and the aortic valve. From the left ventricular aspect, here we can see the area of fibrous continuity between the aortic valve and pulmonary valve at the roof of this doubly committed and juxta-arterial defect. And along the posterior inferior border, there is that muscle bar where the caudal arm of the septal band joins the inner heart curvature or the ventriculo-infundibular fold. This muscle bar interposes between the tricuspid and mitral valves, and as well between the tricuspid and aortic valves. It also allows for the membranous septum, which is quite small in this particular case, to remain intact, so that the conduction axis will emerge from the atrioventricular portion of the membranous septum and run along the posterior inferior border of this doubly committed and juxta-arterial defect, with a muscle bar interposing between the atrioventricular valves and the aortic valve. This is yet another specimen of a doubly committed and juxta-arterial ventricular septal defect. It is a defect that extends into the outlet of the right ventricle and between the limbs of the septal band. The phenotypic feature of these defects is the fibrous continuity in the roof of the defect between the pulmonary and aortic valves, which you can see is quite extensive in this particular case and shows very nicely at the roof of the defect. The reason I'm showing this particular specimen is to show you that doubly committed and juxta-arterial ventricular septal defects can extend to become perimembranous, so that you see the caudal arm of the septal band has failed to reach the inner heart curvature, and there is fibrous continuity between the tricuspid and mitral valves along the posterior inferior aspect of the defect, so that again our conduction axis would run along this posterior inferior border of the ventricular septal defect. So this defect is perimembranous because of the fibrous continuity with the tricuspid and mitral valves along the posterior inferior aspect. Again, the conduction tissue will emerge from the atrioventricular component of the membranous septum and run along the posterior inferior border of this perimembranous ventricular septal defect.
So what Diane has now shown you is that when we have juxta-arterial defects, in most instances, the defects themselves have a myocardial posterior-inferior rim. It's the same rim we saw in the setting of the muscular outlet defect. But what she has also shown you in that second heart with a juxta-arterial defect is that, on occasion, the defect can extend so that it borders on that area of fibrous continuity between the leaflets of the mitral and tricuspid valves. And you will remember from last week that it is the presence of mitral to tricuspid valvar continuity that produces the phenotypic feature of the Peri-Membranous defect. We used to think it was aortic to tricuspid continuity. We now know it is mitral to tricuspid continuity. And that is because we also know that the isolated perimembranous defect represents the unclosed tertiary interventricular communication. So let me remind you what we are talking about here, because this is the situation after the embryo has built the muscular roof, the muscular shelf in the roof of the right ventricle, but has yet to close that tertiary foramen. So in building the roof, the secondary interventricular communication is becoming the left ventricular outflow tract. But there is the persisting channel between the aortic root and the right ventricle. You will recall that aortoventricular communication is the tertiary interventricular communication. I showed you this picture last week. We're looking at the same data set from beneath. So you see the left ventricle The muscular ventricular septum, again, you see those trabeculations that are coming together to form the septum, the subpulmonary outflow tract, and there is the muscular shelf formed from those fused proximal outflow cushions. And there is the persisting aorto-right ventricular communication. And that is what we have to close to complete septation, and the embryo does that by fusing together the tubercles of the atrioventricular cushions. Reverting again to our mice in which we perturbed the furin enzyme, we know that on occasion the embryo is unable to close that tertiary foramen. So here in a mouse with such a defect, we see that the secondary foramen is now remodeled to be the left ventricular outflow tract, but there is the ventricular septal defect, the persisting communication between the right ventricle and the aortic root. You see there is aortic to tricuspid discontinuity. The phenotypic feature is continuity between the developing leaflets of the mitral and the tricuspid valve. But the reason that the embryo is unable to close that hole is because the myocardium is deficient in the area around the defect. So the reason we get these defects and the reason we call them perimembranous is because the muscular ventricular septum is deficient in the area around what should become the membranous septum. And we now have evidence to prove that that is taking place. This, in fact, is a wild-type mice. You see, it's embryonic day 16.5. By this stage, the interventricular communication should have closed. But in this mouse, this wild-type mouse, it has not closed. There you recognize the pulmonary root, the aortic root, and there is a persisting ventricular septal defect. It's an outlet defect. It's opening to the right ventricle centrally between the limbs of the septomarginal trabeculation, and it's bordered posterior-inferiorly by fibrous continuity between what will become the leaflets of the mitral and tricuspid valves. So it is a perimembranous defect, and what you can see, it has persisted because those outflow cushions have muscularized, but they are hypoplastic, and therefore they have left behind an area that is too great to be closed by those tubercles of the atrioventricular cushions. It is a perimembranous ventricular septal defect. And Diane now is going to show you the features of these perimembranous defects. So they exist because of the deficiencies of their myocardial borders. So what she's going to show you is that according to the part of the muscular septum that is deficient, they can open centrally, the base of the ventricle, they can extend so that they open mostly to the inlet, or the outlet, they can be confluent, they can be associated with malalignment of that muscular outlet septum. But the key feature, whenever they are perimembranous and there is atrioventricular septal alignment, then always the atrioventricular conduction axis will be postero-inferior. So now Diane will show you the various lesions that we group together as being perimembranous because of the phenotypic feature, fibrous continuity between the leaflets of the mitral and tricuspid valves.
In this tiny heart, we see a ventricular septal defect that is opening centrally at the base of the right ventricle. And this defect is as a result of failure of closure of the embryonic interventricular communication. The septal leaflet of the tricuspid valve lies here, and the anterior superior leaflet is here. This defect lies beneath the zone of apposition between the anterior superior and the septal leaflets of the tricuspid valve. The supraventricular crest, in this particular case, inserts normally within the Y of the septal band. Here we can see the medial papillary muscle arising from the caudal arm of the septal band, so that the defect is inferior to the supraventricular crest. If we look at the markers for the triangle of Koch, we can see the coronary sinus, which is at its base, and if I lift upward on it, you can see nicely highlighted by the light the prominence of the tendon of Tadaro extending to the apex of the triangle of Koch with its other arm marked by the septal hinge of the tricuspid valve. So if we look at the borders of this defect, we can see by drawing a line from the apex of the triangle of Koch to the medial papillary muscle that this conduction axis is going to run along the posterior inferior border of that defect. Looking at the phenotypic features of this central perimembranous ventricular septal defect, we see the aorta to mitral valve fibrous continuity, and in the posterior inferior position, we see a remnant of the membranous septum, and we know that the atrioventricular conduction axis penetrates in this area so that it must run inferiorly to the border of the defect. It used to be thought in the past that one needed tricuspid to aortic fibrous continuity to declare a defect perimembranous, but that is no longer the case. And in this particular heart, we can see this muscle bar running interference between the tricuspid valve and the aortic valve. And this muscular bar is a component of the outlet septum where it failed to fuse during development. So in this particular defect, there is fibrous continuity along the posterior inferior rim between the mitral valve and the tricuspid valve. And this is now the hallmark or the specific descriptive characteristic of a perimembranous ventricular septal defect. The borders of this perimembranous ventricular septal defect tells us the position of the conduction axis along the posterior inferior border, and the geography tells us that it opens centrally into the roof of the right ventricle. The defect occurs in the confines of, or in the muscle, in the area adjacent to the membranous septum, hence the name Perimembranous. This particular specimen shows us yet another central perimembranous ventricular septal defect. Just as the last specimen showed us, it arises centrally at the base of the right ventricle and at the zone of apposition between the septal and the anterior superior leaflets. It is also inferior to the supraventricular crest, which inserts normally between the limbs of the septal band. There's the cranial limb and the caudal limb and the medial papillary muscle. Looking at the landmarks for the triangle of Koch, the coronary sinus opening is here. The majority of the atrial septum has been removed in this specimen for other anatomic illustration, but here is the tendon of Tadaro and the hinge point of the tricuspid valve marking the apex of the triangle of Koch, so that the conduction axis will run along the posterior inferior border of this perimembranous defect. Looking at the phenotypic features from the left ventricular aspect, here is the aorta to mitral fibrous continuity. In this particular specimen, there are a few chordal attachments that are crossing the interventricular septum. But the reason I'm showing this particular central perimembranous ventricular septal defect is to show that there is fibrous continuity in this particular specimen between the tricuspid and aortic valves, as well as along the posterior inferior rim fibrous continuity between the tricuspid and mitral valves. So that we know that the conduction axis penetrates through the atrioventricular component of the membranous septum along this posterior and will run along this posterior inferior rim of the defect. The anterior free wall of this right ventricle has been removed, showing us the tricuspid valve within the inlet portion and the pulmonary valve in the outlet component, supported by a complete muscular infundibulum. There's also a quite large ventricular septal defect that extends both into the outlet and the inlet portions of this right ventricle. The inlet portion extends beneath the septal leaflet of the tricuspid valve, and the outlet portion between the limbs of the septomarginal trabeculation. This also accounts for the anterior cephalic deviation of the outlet septum. This outlet septum does not cause subpulmonary stenosis in this particular case. Tilting the defect or the apex of the heart upwards, we can see the aortic valve in the roof of the defect slightly overriding the malaligned septum. Also, there's a quite extensive area of tricuspid to mitral valve fibrous continuity at the posterior inferior border of the defect. Looking from the left ventricular aspect, there is the mitral valve with its fibrous continuity between it and the aortic valve. Also, there's a superior muscle bar which marks the area separating the aortic root and the subpulmonary infundibulum. We have an extensive area of tricuspid to mitral fibrous continuity where the defect extends into the inlet component of the septum, and there's also tricuspid to aortic fibrous continuity. The conduction tissue will run along the posterior inferior border of this confluent perimembranous ventricular septal defect that extends both into the inlet and outlet components of the right ventricle. There's also a mid-muscular septal defect in this particular case. This is a larger defect that opens centrally within the base of the right ventricle. This time, the defect extends to open into the inlet component of the right ventricle. Looking along the posterior inferior border of the defect, there's an extensive area of tricuspid to mitral valve fibrous continuity. And at the roof of the defect, there's the aortic valve with aortic to tricuspid fibrous continuity. Looking at the supraventricular crest, here it inserts normally within the limbs of the septal band, and the medial papillary muscle is arising from that caudal limb. If we look at the markers for the triangle of Koch, the coronary sinus is at its base. This heart also has a fenestrated so-called secundum type of atrial septal defect. And when I tug on the eustachian valve, we can see the tendon of Todaro with the other tricuspid valve. In this particular case, the apex of the triangle of Koch is pushed inferiorly, secondary to this large inlet ventricular septal defect, so that the atrioventricular conduction axis will be at the point inferiorly where the muscular ventricular septum meets the atrial musculature. The left ventricular aspect shows us the extension into the inlet portion of the ventricular septum, the mitral to aortic fibrous continuity, and the tricuspid to mitral fibrous continuity. In this area, there's a small remnant or flap remaining from the membranous septum, and here you can see the fibrous continuity between the aortic and tricuspid valves. In this particular case, the conduction axis will arise where the crest of the muscular ventricular septum meets the atrial musculature and will run along the posterior inferior border of this perimembranous defect that extends into the inlet of the right ventricle. We're going to revisit a specimen from last week's discussion, and this particular ventricular septal defect extends into the outlet component of the right ventricle so that it opens between the limbs of the septal band. The supraventricular crest in this particular case is deviated posterior caudally, and the muscular outlet septum, as we'll see from the left ventricle, will interpose between the aortic and the tricuspid valves. From the right ventricular aspect, you can see the extensive area of fibrous continuity between the tricuspid and mitral valves along the posterior inferior border. And when we look from the left ventricular aspect, there is the posterior deviation of the outlet septum, so that this subaortic outflow tract is separated from the subpulmonary infundibulum by this bar of muscle or the outlet septum. This muscle bar produces discontinuity between the aortic valve and the tricuspid valve, and this gives us an exemplary example of the key feature of perimembranous ventricular septal defects. Here we see the tricuspid to mitral valve fibrous continuity along the posterior inferior border of this perimembranous ventricular septal defect. The conduction axis, again, would penetrate through the atrioventricular portion of the membranous septum and run along this posterior inferior border of the right ventricle, of the left ventricle. This heart represents yet another type of perimembranous ventricular septal defect. This defect opening into the outlet component of the right ventricle. It's perimembranous because of the fibrous continuity between the tricuspid and mitral valves. This defect is secondary to malalignment of the supraventricular crest relative to the limbs of the septal band. So therefore it opens between the limbs of the septal band. When we look at the conduction axis, we can mark the triangle of Koch, the coronary sinus at its base, the tendon of Todaro, and the tricuspid valve hinge point. Mark the apex and the conduction tissue if we draw a line from the apex of the triangle of Koch to the medial papillary muscle, again will run along the posterior inferior border of this perimembranous defect that extends to the outlet of the right ventricle. When we look at the left ventricular aspect, in this particular specimen, a portion of the left atrium, mitral valve, and the non-coronary aortic leaflet have been resected, but we can still appreciate a little bit of the aorta to mitral valve fibrous continuity. The right coronary aortic leaflet and sinus. There's the right coronary orifice. And here is our perimembranous ventricular septal defect. At the posterior inferior border, there is fibrous continuity between the tricuspid and mitral valves. This bar of muscle is the leading edge of the supraventricular crest and demonstrates the malalignment seen in this particular outlet ventricular septal defect. This is the muscular outlet septum that is actually interposing between the aortic root and the subpulmonary infundibulum. The conduction axis will run again along the posterior inferior border of the defect as it penetrates through the atrioventricular component of the membranous septum. This particular specimen shows us yet another perimembranous ventricular septal defect extending into the outlet component of the right ventricle. In this particular case, the septal malalignment is in anterior cephalic position, and this is the type of malalignment you see associated with tetralogy of Fallot, whereas in this particular specimen, the subpulmonary outflow tract is wide open. This defect is perimembranous, secondary to the fibrous continuity between the tricuspid and mitral valves. And this defect opens between the limbs of the septal band. The aorta overrides the ventricular septum in this particular defect, and the valve is lying within the roof of the defect. You can easily access the aorta from the right ventricle, and there is aorta to tricuspid fibrous continuity. The conduction axis, again, is going to run along the posterior inferior border of this defect as viewed from the right ventricle. The left ventricular aspect also shows us that there's a small inferior muscular ventricular septal defect associated with this perimembranous outlet ventricular septal defect. The aortic to mitral fibrous continuity is in this area. The muscular bar marking the outlet septum. And here is the area of tricuspid to aortic fibrous continuity. Along the posterior inferior border, there is also tricuspid to mitral fibrous continuity, which is the key feature in identifying perimembranous ventricular septal defects.
So we've seen a lot of hearts this afternoon, and hopefully by linking that to concepts which we now know explain normal development, I hope we've been able to show you how we can relate the phenotypic differences in isolated ventricular septal defects to the developmental mechanisms. And what I've also hoped we've been able to show you is that the differences between those defects reflect their borders. And it is the variation in the borders rather than the geography itself that permits the recognition of those phenotypes. Now, this is not to deny the importance of geography. Geography is important since it tells you as clinicians, particularly surgeons, how to approach the defect. Are they in the inlet? Are they in the outlet? Are they apically? Are they at the base of the ventricular mass? This is important information. Also important is to recognize the presence or absence of alignment between the septal components. But what I hope we've emphasized that in order to distinguish the phenotypes, we have to concentrate on the borders, and those borders can now be related to the steps involved in development of the heart.
So, Alan, what do you think? Was an amazing excursion. Is a tom-tom for surgeon, is a tom-tom for cardiology, the geography was so amazing. So your comment.
I think borders and geography are both important. I think I'm interested in the outlet muscular VSDs, okay? My question is for Diane and Bob is, first of all, is there always malalignment to the outlet septum in that situation? And can it be either anterior or posterior malalignment? And secondly, do you think these defects can ever close spontaneously?
Well, let me try and answer that first. Your first question, is there always malalignment? No. If the outlet septum is simply hypoplastic, then that will give you the hole pointing between the two outlets, and the aortic root, the pulmonary root, can be aligned with their own ventricles. Do you find malalignment? Certainly. You get the muscular malalignment outlet defect in the setting of tetralogy, for example, and then there can be that muscular posterior inferior rim. Diane showed you the very nice example where there was caudal malalignment, and then that is the one that is associated with subaortic obstruction in the setting of concordant ventricular arterial connections. So there we would be expecting cooptation or interruption. So all three variants are possible in the setting of the muscular outlet defect, with simply a hypoplastic outlet septum, with anterocephalad malalignment, with posterocaudal malalignment. So I think that you have to put it all together. You have to anticipate these things. You can have exactly the same thing when the defect is perimembranous. In fact, you can then extend it, and you can also say you can have the same thing with the doubly committed juxta-arterial defect, but then it will be the fibrous outlet septum that will be malaligned. It might be in the middle without malalignment, then the aortic root, the pulmonary root will be of comparable size. You have anterocephalad malalignment, then typically that will be small pulmonary root, larger aortic root. You have it the other way around. If you have caudal malalignment, then the aortic root will be small, the aortic root will be large. So I think that the concept that you've asked, is there always malalignment? No, there isn't. But the concept that you've established by asking the question is applicable in all of these outlet defects.
And do you think, secondly, that an outlet defect, no matter how small it is, will ever close itself?
Now, that's another very good question. I think if it's a tiny defect, and we have seen tiny defects, then I think there is the possibility that fibrous tissue can accrue around the margins of the defect. And I have seen examples like that, and I've seen them when they are virtually closed. So we only see what we get to see. So I think that there is the chance that that can close. Contrariwise, I think if there is any size to the defect, it's most unlikely to close unless it closes by prolapse of the leaflet of the aortic valve. And that's the one thing that we haven't discussed today, because with all of these defects, particularly when you have a hypoplastic outlet septum or when you have a fibrous outlet septum, then the aortic root is losing the support that's provided by the outlet septum, the supraventricular crest, and it's far more likely in that setting to prolapse. And then you can certainly have blockage of that defect by prolapse of the leaflets of the aortic valve. But you know better than I that we don't want that to happen. So that if they have spontaneous closure by prolapse of the leaflets, I guess that's not a good thing, and you would rather avoid that, would you not?
No.
Bob, there is a sorry.
Who's saying something?
Yes, yeah, I'm saying it. There is a question by Jaime. I think it's very important, very, I am curious also. How often you find mitral tricuspid continuity versus tricuspid aortic continuity in perimembranous BSD?
Now, this is a question that we were also asked last week by Rodney Franklin. He posed that question. And it's only within the last 18 months or so that we have appreciated that, in fact, it is mitral to tricuspid continuity that is the defining feature. So it's relatively recently that we've started looking for the cases in which there is aortic to tricuspid discontinuity. So off the top of my head, last week I said that it was about 1/10 of the cases. I saw we had Diane with us a moment ago. She seems to have disappeared again.
I'm still here.
You're still there. So we wrote a paper that we published in Orphanet with Justin Tretter as the first author. And I think that we gave some numbers there, did we not, Diane? Do you know what those numbers were?
I don't remember at the moment, but I think that the central perimembranous ventricular septal defects, probably a lower number had absence of tricuspid to aortic fibrous continuity than did aorta to tricuspid fibrous continuity, but they do exist, even though they are less in number.
Indeed, you showed that one of the cases, the first central perimembranous defect you showed us today had aortic to tricuspid discontinuity, but continuity between the mitral valves and the tricuspid valves. So at the moment, I don't think we can give a cast iron answer to that question. It's a very good question, but I think that also this is a question that needs to be answered by looking at it in the clinical setting. I mean, Alan, how easy do you think it will be to distinguish between mitral to tricuspid, aortic to tricuspid continuity?
An echo, sometimes very difficult. I think the surgeon knows best.
Yes. This was the case because I was interested in know this, because we can say, I can say that, as Bob said, most of the case, for example, in what we call perimembranous VSD with in different pathology or part of different pathology, I think that the mitral aortic continuity is always present. What we can say 100%. But what about mitral tricuspid? Probably something that we don't take really care. This is the opportunity to look better at the next case.
Indeed.
But this is what I think is very important. Bob, there is 2 questions from Paolo Zielinski. I know that you like him, the question he make. So he asking, probably the first is for Diane. And he say, in a very large muscular trabecular BSD, which extends upward to the vicinity of a coexistent perimembranous defect, leaving just a very small muscular ridge between the 2 defects. Could we say that the conduction tissue would run in this remnant of the perimembranous, of the membranous septum? This is a question also that, you know, sometimes surgeons, when they decide to cut or to reduce this ridge, the patient, mostly of the case, met IV block. So I'm very curious about the answer of this. Probably, I don't know if Diane.
That the conduction tissue will run in that muscular bar between the 2 defects, and it just depends on how big that muscular bar is as to where the surgeon can place their sutures. And as you said, Sasha, if that muscle bar is cut, those patients do have conduction issues.
Yes. And in fact, it's a very good point that is raised. I mean, Alan is now working in Southampton. Alan started his career at the Brompton, as did I, and then he moved down to Southampton. I think Jim Monroe was not there any longer when you arrived, was he, Alan?
He wasn't any longer, no.
But Jim Monroe was an outstanding pediatric cardiac surgeon who worked in Southampton, and he was one of the first people to try to do infant correction of tetralogy of Fallot during infancy. And one of the first patients he had that he tried to correct had a perimembranous defect associated with a muscular inlet defect. And the bar of tissue between the 2 was tiny, and he put 1 stitch to close the perimembranous defect and another one to close the inlet. And sadly, he sandwiched the bundle between the two. And he sent that heart to me. So we're talking now 1976. It's a long time ago, 1977. And he had sandwiched the bundle between the two. And that was about the only heart he lost. He was an outstanding pediatric cardiac surgeon. His results were quite spectacular. But that, to me, was the message that whenever you have that muscle bar that Paolo is asking about, no matter how narrow it is, if it is between a perimembranous defect, a muscular inlet defect, it will carry the conduction system. And I think now, Sasha, you would know that either you put a big patch across both defects, or else you wait for the patient to get a little bit older if you want to put two separate patches.
Yes, I think that we realize this because we learn from people as pioneers start to have conduction tissue problem. And I think that if you can wait, it's better to wait, because heavy block is every time a very bad situation. So the second question, I think, is more for you, from Paolo, is about outlet septum. He is asking, in a Hughes arterial double committed ventricular septal defect, being the roof of the defect, the fibrous shelf that originate by fused but not muscularized parietal and septal cushion, could we say that the outlet septum is still present? First question. Albeit fibrous, second question, or rather that this fibrous shelf is not an outlet septum?
No, I think his first point is correct. I think it is an outlet septum. I think we know from our work that I keep on showing you with our furin mice that it is derived from the fused cushions. The cushions, the distal part of the cushions have properly fused, which is why we have the two arterial roots. We also know that you don't always see that raphe. So sometimes it's flush with the base of the two leaflets, but increasingly, as we look at more and more of these defects, we see that remnant. And as I say, it can also be deviated cephalad, it can be deviated caudad. So I am sure it is the remnant of the outlet septum, but the point that Paolo makes, it is a fibrous outlet septum rather than a muscular outlet septum. There's also, Sasha, I note that under the question and answer box, there's also two very good questions from Matteo Rios. I don't know whether Matteo is still with us, but he's asking, and he says, do you consider that it would be more practical to classify VSD on the failure of the embryonic septal formation than the current classification? Now, that depends exclusively on what you think of as your current classification, because I think that the system we're now proposing, the juxta-arterial defect versus the muscular defect versus the perimembranous defect, I think that is entirely consistent with what Diane has shown you today. So I think that borders classification in that basis, the three types, adding to that the geography, is entirely consistent both with the embryology and with the morphology. But Matteo then goes on to say, if the muscular VSDs are a result of failure of compaction, why do we not see these defects in non-compaction of the ventricular mass? And that is because what you call non-compaction of the ventricular mass is not due to failure of compaction of the walls of the ventricles. What currently you call non-compaction is excessive trabeculation, and it is not the same thing at all. So in the setting of so-called non-compaction, the trabecular layer has continued to grow and has maintained its proportions relative to the compact layer. And this is why non-compaction is a terrible term. But interestingly, if you look carefully, and Vera Aiello has done a very nice study of this in her hearts that she has in São Paulo, and she has found that when you have the muscular defects in the ventricular septum, you also have excessive trabeculation. So it's a good question that Matteo asks, but you do have excessive trabeculation associated with the so-called Swiss cheese septum. There's another good question about the Swiss cheese septum. Why sometimes do you have multiple defects? Other times you have a solitary defect crossed by trabeculations, and that all depends on the extent of the trabeculation.
There is a big message by Rodney Franklin. I was asking him if he want to intervene live, or I give him the opportunity to open the microphone. This is a fantastic paper from 2019 on orphanet. He realized that over, I don't know, more than 365 cases, they found that in all arts, here he is. Hi,
Hello, Rodney. Welcome.
Hi, Rodney.
Thank you. Hi, and I've been enjoying these talks immensely. No, this is just Bob's paper he was quoting. I did take a copy of it because Bob sent it around to the nomenclature group some time ago, and we are proposing eventually to update our descriptions in the ICD-11 to accommodate this by adding in a recognition of the need for tricuspid mitral continuity as the hallmark. As the overriding hallmark, but that's not to say that aortic and tricuspid continuity is worthless in that sense.
Oh, absolutely. I agree with that 100%. And I mean, you also, Rodney, you must have looked at these things knowing what we've been discussing over the years in terms of how easy it is to see it echocardiographically. As Alan says, it's not easy to do that. It's not easy to make the differentiation, is it?
No, I think that it's opened up a new area for us to investigate, because we hadn't really sort of thought about it particularly. One concentrated on the aortic tricuspid continuity, and now one has to reconsider that to some extent with these hearts, although it is a minority.
Did we actually give numbers in the paper?
Yeah, so it's actually a bit higher than you suggest. It's actually 80% of cases 20% of cases or so did not have aortic tricuspid continuity. So it's a substantial proportion of a lot of hearts.
Well, just to show how easy it is for me to forget things I did last year. I can remember everything that happened 50 years ago. I'm losing touch with what happened last week.
Could also commend the paper, 2018 paper in the Annals of Thoracic Surgery, the classification paper, to other participants. A very good description of VSDs. It's excellent. It's good diagrams.
Indeed, and that's where we moved forward from, and that was the basis of what we subsequently did with the orphanet paper, because and as Rodney says, this in many ways is a work in progress, and Rodney is now translating all of these things into ICD-11. And has it appeared, Rodney?
No, if you look on the ICD-11 site, all the VSD classifications we published in 2018, I think it was, the VSD paper with Leo as a lead author, Leo Lopez, all of that classification is there. The definitions are the things which may require some modification given this new work, and also the fact that we don't have a confluent defect there at present, which I think is something would be valuable.
You saw that beautifully in one of the hearts that Diane showed, the big heart, where that defect extended all the way from the malaligned outlet septum down to the inlet. And I think, Sasha, that must be a nightmare for you as a surgeon when you see something as big as that.
Yes, very amazing. It's so huge. That is fantastic to see, because Diane is able to show in a way that we suffer to that never look like this. So we are so happy, and I think that this make all over the world people look at BSD like this. This is a fantastic tools to improve the surgeon approach and reduce postoperative residual BSD, because now mostly we understand where the things are. So Bob, there is another one question. I thanks also Rodney, because it was a big pleasure of him.
Thank you for inviting me.
You please are most welcome, whatever you want. We really appreciate your presence. So there is the last question is from Carlo Troconis. You know him.
Yeah.
He's asking about Gerbode defect.
Back to the good old Devotee defect. Well,
Waiting for
Indeed,
the
that's another good question. I mean, the Devotee defect, we're now back to the Frank Devotee, the famous surgeon, who, well, famous to me, but we're now back to more than 50 years ago. In fact, 1956, when Devotee published his paper on the defect that permits shunting between the left ventricle and the right atrium. And there are two types of Devotee defects. The one is the so-called direct Devotee defect, and that is a deficiency of the atrioventricular component of the membranous septum, and it is as rare as hen's teeth. I have never seen an autopsy heart with a direct Devotee defect. The second one, which is much commoner, is the indirect Devotee defect, and that is when you have the perimembranous defect that then shunts initially into the ventricle and then up into the right atrium through a deficiency in the septal leaflet of the tricuspid valve. Much commoner, but again, is Diane saying something? It says on my screen, Diane's talking. Does Diane want to say something?
I was muted. Sorry if my sound was coming through.
Oh, it said you were speaking, but obviously you weren't. So,
No.
but you would agree, Diane, that it's very difficult for us with the specimens in our hands to determine precisely when a perimembranous defect would also shunt up into the right atrium.
Yeah, I agree.
And if you've never seen a direct defect of the atrioventricular component of the membranous septum, have you, Diane?
No, I've never seen a Devotee defect other than in a picture in a book or one that Dr. Backer repaired at Lurie Children's in Chicago.
And that was the amazing thing, because Carl at Lurie had a series of 6. And in each of these, he insufflated the right ventricle, blew up the tricuspid valve, showed the tricuspid valve was competent, and still there was fluid coming up from the left ventricular outflow tract. So why he should have come across 6, goodness knows. There are a couple described by Roxanne Mackay whilst she was in Liverpool, and Jim Wilkinson, I know, my very good friend Jim Wilkinson, still practicing in Melbourne. Jim was called into the operating room and confirmed with Roxanne that it was a defect of the atrioventricular membranous septum. But Alan, have you ever seen one?
I was about to say, I've seen it described in interventional meeting as a complication. I don't know how they did it. I've never seen it otherwise.
Sasha, have you ever seen one?
No. Never happens. So Bob,
Oh, we've had, I mean, it's amazing because we've had a long time today. We saw a lot of hearts. We were going, Diane did a magnificent job in demonstrating all those hearts.
yes.
It's good to see that we still have 146 interested participants who are watching and listening to us. So I think we should give Diane a very big round of applause for making those exquisite clips, because I think it was spectacular.
Very good. Bob, can you please introduce the month of March with the next speech?
Indeed. So I can tell you what we have coming. So already next week, we have prepared a series where we're going to show you the features of dominant left ventricle. So we're going to return to the functionally univentricular heart. I noticed when Grace was talking about what Merrill is going to be talking about, she's talking about single ventricle. I hope we can persuade her that in fact she's talking about the functionally single ventricle. But next week, we're going to show you what happens when you have a big dominant left ventricle and you have an incomplete right ventricle. So Diane has already prepared the images to show you what happens when you have tricuspid atresia, what happens when you have double inlet left ventricle. Then I spoke today with Adrian Cruchan. Adrian, I'm sure, has been watching today, or he will be watching. So the week after that, so in 2 weeks' time, we're going to talk about what happens when you have univentricular connection to a dominant right ventricle. So then it will be the left ventricle that will be incomplete. And so we're going to show the much rarer variants of double inlet right ventricle. Now, Rodney, will be very interested in this because, again, a long time ago, Rodney did his thesis on double inlet ventricles. So Rodney knows all about double inlet left ventricle, double inlet right ventricle, and that will be the focus of our next 2 weeks. And then the final week on March, we're going to be discussing straddling atrioventricular valves. And what we're going to be showing you is the spectrum we have between straddling valves, between double inlet, and then the spectrum then is between straddling of the right AV valve, which goes to concordant AV connection, straddling of the left AV valve, that goes to congenitally corrected transposition. And we'll be discussing all of that with you. And we'll also show similar spectrums that we have in the setting of double inlet right ventricle.
So thank you very much. Hoping to see you next Friday.
Alan, thank you very much for being with us. We hope you'll enjoy it. You'll be with us and you'll comment.
I can't come next week. Maybe Rodney wants to come next week instead. I can't make it next week.
Rodney, are you still with us?
Yes, hold on.
Right, to be appropriate next week, since, as I say, you know more about double inlet left ventricle than anybody.
I will try. There is a slight clash. It's my wife's birthday. And,
oh my goodness, we can't take you away from your wife's birthday. We wouldn't want to do that.
No chance, no chance.
Maybe Norman. Maybe we can have Norman with us again next week.
So
but the week after I'm free.
Thank you very much. Thanks to all the people from all over the world you see on the chat, Uruguay, Iraq, Jordan, Mexico. So we are very happy for this. Bob, thanks a lot. Diane, your specimen was more than Picasso. It was
absolutely
fantastic. Thanks.
I keep on telling everybody, though, it's not Picasso, it's Rembrandt, because Diane is showing you the real thing rather than the Picasso version of it.
No,
also, Sasha, I should say that the music at the start, the cellos this week to start off were fantastic. Yeah. I love the cellos.
We will see again. We will use again. So thank you very much. See you next week. Thank you, Alan. Bye, Rodney. We will invite you, Rodney. We will receive invitation for this. Diane.
Thank you.
Have a nice day.
Diane's still there. We should say again, yeah. Diane, thank you. That was great.
I'm still here. Thanks. I had to use my phone this week, so.
Thank you very much. So, Bob, we have thanks from Indonesia. Christina from Indonesia.
Right.
Thank you.
We're glad that everybody is enjoying it. The sessions are getting better week by week.
Yes. Okay. See you next week.
Ciao.
Thank you.
Bye-bye.